Hi, this is Brian Kim. I want to share with you this case of a patient with a pretty severe injury. He had a traumatic injury with facial lacerations and also developed a traumatic cataract. And there's about 3 or 4 clock hours of zonular dehiscence. And you're going to see how I struggle through this case. He has a dense cataract, zonular dehiscence, and I have to do some extra steps throughout the procedure. I use Trypan blue, but then I lost my red reflex completely because the Trypan blue bled into the vitreous space. I placed a capsular tension ring, capsule retractors, and then a sutured capsular tension segment in this traumatic cataract with zonular dehiscence. So you can see this is a cataract, and as you can see, this quadrant on the left side is actually more like maybe 1/3 of the zonules on that left side of the screen are gone, but maybe 120 degrees. I use a corneal mark. But you see I'm making the mark a little bit eccentric because I'm trying to make the corneal indentation over the lens, not over the pupil. Because when I do the rhexis, I need to make sure I'm over the lens itself. I make my incisions on the right side and then the left side. This is some intracameral epinephrine and then some dispersive viscoelastic to coat the cornea and to flatten the anterior capsule. Again, no real zonules on that left side of the screen. This is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter here. And you know that the zonules are weak because when I go in there to do the capsulotomy, as I try to puncture with these sharp tip microforceps, nothing's really happening. As you can see, this is called the spider sign. I've been calling this the spider sign, which reflects zonular laxity. And I could have proceeded here, and I did puncture a little bit, but you can see how much traction there is on the bag as I puncture and I pull down. You can see the entire lens is moving, and so I didn't really feel comfortable with that. And also I felt like maybe I need to stain the capsule because if I lose my way, I'll have a hard time visualizing the capsule, and then it'll go from bad to worse. And so I hesitate, I think about it, and I stop. I come out and then I start to paint the anterior capsule with the Trypan. It's a little bit of a challenge to paint the anterior capsule with Trypan when the viscoelastic is already in the eye. But what you have to do is manually and physically rub the stain, the dye, onto the anterior capsule. So that's what you're seeing here. I'm literally rubbing and massaging the dye on the surface of the anterior capsule. But look here, as I push, instead of being isolated into the center, the dye, you see there's a little bit of spillage on the left side of your screen at about 9 o'clock. You can see there's a portal of dye that's going posteriorly here. Now, it's not that obvious, but now as I push more, you can see that dye is really seeping and bleeding into the vitreous space on the left side. And so I said, okay, I'm not going to do that anymore. So I pushed some dispersive viscoelastic to tamponade any more dye from going into the back of the eye, but you know, it's already happened, and so I just go ahead and try to finish off the case. Again, the capsulotomy was difficult to visualize. Now that the Trypan has stained the capsule, I'm able to see it much better. And it's a fine line. You don't want to make a huge rhexis, but you don't want to make a tiny rhexis. And this one is a little bit on the smallish side, but that's because I'm already anticipating that I'm going to have to place a capsule tension segment possibly. And you want to have a robust anterior capsule rim when you're suturing a capsule tension segment, and also when you're dealing with capsule retractors. This is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, get a nice little wave here. Very careful and slow hydrodissection in this context, gently trying to decompress the bag without stressing the zonules. Not going to try to spin this lens in this case with known zonular loss. Lifting the incision, going in with irrigation off, and then activating irrigation. You can see the lens is wanting to come forward. But I'm a little concerned because you can tell that the lens is coming forward and there's some loss of integrity on the left side. So I go back and push some more viscoelastic, and I decide to place some capsule retractors. So these are my incisions for 2 capsule retractors that are about 90 degrees apart. It slides right in, and these are from MST. I have no financial interest in them. And you go in, and these are the traditional ones. When you push it in, it just bends on itself, and it pops into the anterior chamber. And then you can reposition it and hook the anterior capsule edge and getting that distal part, the hook part, the retractor part within the capsular bag, and you get better fornicele support and retraction of the capsular bag. So I slide the chopper under the rexus edge contra-incisionally, the phaco tip vertically sub-incisionally, and that is the double chop maneuver. And sometimes traumatic cataracts can be rather soft, but this cataract has a little bit of meat to it, a little bit of density as well. This is the cross chop maneuver. I'm placing the chopper under the right heminucleus, hooking the peripheral lens, and then pulling it centrally, cutting the lens against the phaco tip. Lifting that first quadrant up with some vacuum and very carefully removing that piece. And as you can tell very quickly here, my view is terrible. I cannot see very well at all because of that Trypan blue that seeped into the vitreous space, but I have tremendous confidence in my techniques and leveraging mechanical fracturing forces and not relying on high vacuum to grab pieces up out of the bag. And as a result, I know that I'm not going to cause any serious problems because I'm not going to do anything risky when I'm trying to pull these pieces up. Again, with other techniques, people are more reliant on trying to use vacuum and ultrasonic energy. And when you have a challenging situation, it could be dire because you can rupture the posterior capsule. But you see here, I used the chopper to hook that lens piece up. And by using mechanical forces, and in my case, using the chopper to lift pieces up out of the bag, and then flanking the 2 instruments, the chopper and the phaco tip, around the lens pieces, I can more effectively fracture the lens pieces. Here, I notice that I'm stuck, and so I take the instruments out. I push some BSS to re-hydrodissect, but you saw here I also used the chopper to hook the lens piece up out of the bag, and now the lens is free. So you can see that you can use my cannula because it's right-angled. My hydrodissection cannula also act as a hook to lift that piece up out of the bag. So again, really nice advantage of using the Kim hydrodissection cannula because it is right-angled and it's long, and I'm able to hook that lens piece up, which was on the left side of the screen, which was underneath my chopper tip there. Very easy and efficient way to get that lens out of the bag. And again, my view is still pretty terrible, but I'm just taking my time, used a little bit of vacuum to grab that piece, and then very carefully emulsifying the lens pieces, pulsing some ultrasonic energy as I go, but primarily relying on mechanical fracturing as well as high vacuum. And again, the view is really terrible, and that's because of that Trypan blue. But you can see I tumbled that lens piece up out of the bag using a 2-handed technique, using the chopper and the phaco tip right there. Again, it's relying not just on mechanical fracturing, but knowing how to manipulate the lens piece with both hands. And I think that's really the most critical step in this technique. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the eye in a handpiece. You can see I am in a low flow setting with the IOP in the 30s. All of this has been done in a low flow setting because of the Zonular Dehiscence. Switching to polish mode, grabbing some of the sticky cortical materials there. And again, the view is rather limited because of that dye that's in the vitreous space. Pulsing BSS into the subincisional capsule fornix. You can see there's quite a bit of stuff coming out. Another advantage of that technique. Switching to polish mode, polishing more of the posterior capsule as well as the anterior capsule here. And here I'm going to place the capsular retention ring. You can see it's on the platform, but I lift it up and then I have the hook pointed down and I'm able to draw it into the injector. This is the Lester. I go in with the capsular retention ring. I hook the leading eyelet with the Lester, minimizing it from opening up completely, which limits any zonular stress on the capsular bag, making sure it's nice and tight on there, and then deliver the trailing eyelet into the bag. Go ahead and take each of these capsule retractors out, grasping it with microforceps from the inside, pulling it into the anterior chamber, and then very carefully pulling it out of the main incision here. And then again, same technique, grasping the stopper with the other forceps, pulling the capsular retractor into the eye. And very carefully grasping the capsular retractor from the tip, flexing it and stretching it, and then very carefully externalizing it. I'm going to place a traction suture on the right side at the limbus. And that's because I'm anticipating that I'm going to have to place a capsule tension segment and suture it. So perform a peritomy quickly here. And you want to place the peritomy in the area of the zonular dehiscence. Perform some cautery in the area of my partial thickness sclerotomy. So I'm measuring about 1.5 millimeters posterior to the limbus here and here. And I'm going about 2 clock hours, and this is a partial thickness groove, a scleral groove with a diamond blade, and then I'm going to stab full thickness on the ends of the groove. Here, and then here. And this is the capsule tension segment. I like to do this outside the eye. I'm placing the CV8 Gore-Tex suture through the central eyelet, and then cut the needle off. Again, pushing some more cohesive viscoelastic to fill the bag. Placing the capsular retention ring inside the anterior chamber. The only challenge in this case, you're going to see me struggle a little bit, the capsular retention segment is a little bit bigger than the capsulotomy that I made, and it's rather stiff. I have to position the capsular retention segment in such a way that it's fully inside the capsular bag. So you can see here, that's what I'm trying to do here. And I got the first part into it, but the proximal end of the CTS, it's still not quite into the capsular bag. Placing the micro forceps through the sclerotomy and hand shaking it with another microforceps, holding that suture, the Gore-Tex suture, and then externalizing it through the sclerotomy, cutting the other suture and doing the same thing on the other side. This is a pretty long suture, so I just cut it. Again, left hand is going through the sclerotomy, hand shaking through the main incision with the suture, grabbing it with the other forceps, and then pulling it through. So right here, the suture ended up going underneath the CTS. And so I'm trying to reposition in such a way that the suture is above the capsular tension segment now, and that's what I did there. So again, very carefully trying to tuck that trailing part of the CTS into the bag, which I did. Now I'm pulling on the sutures, and now you can see it's providing nice zonular and capsule support. Placing the single piece acrylic lens into the capsular bag now. And again, the capsulotomy is a little bit on the smaller side, but with this single piece acrylic lens, I'm able to tuck it into the bag pretty easily here. Now, as I do this, you'll notice something. The capsular tension segment is actually underneath the lens optic right here on the left side. And so I'm going to have to do some maneuvering to get the optic underneath the capsular tension segment. So that's what you're seeing here. I'm using the viscoelastic cannula to just slide the optic to the right, and the CTS pops up anterior to the optic. Just using the cannula to just flex and move the haptics to make sure that it's not getting snagged and caught up into the capsule tension segment. But you can see that the lens is a little bit shifted towards that right side, and that is because of that zonular dehiscence. And I like to do single throws and titrate the tension on these, because the Gore-Tex, once you tighten it, it doesn't loosen up very well at all. So you have to be very careful that you don't over tighten in this situation. So I just put one throw. Literally, it's going to keep it nice and secure in this situation. Going into the anterior chamber with the IA, I did not go underneath the lens. I just want to be mindful of the capsule and the zonules, plus the capsulotomy is a little bit on the small side. Go ahead and remove all the viscoelastic from the anterior chamber. You can see the lens is nice and centered very well here, and that single throw on the Gore-Tex suture is not loosening whatsoever. Go ahead and hydrate my incisions. Now, one other thing I didn't tell you all is this patient had a traumatic mydriasis. And so this patient's pupil, I mean, it was like this even before we dilated him. Huge pupil, but thankfully no iris tissue loss in this situation. So I'm going to have to deal with that as well later on. Now, this video is already long as it is, so I'm not going to show the fixing of the pupil with the pupillary cerclage. I actually perform a fourth-row pupilloplasty and doing about 4 or 5 fourth-row pupilloplasties to create a cerclage. And so that is going to be on a different video, not on this video. But you can see here, single throws, and I do about, I think, 3 or 4 of them. And you want to be very mindful about the tension as you're putting on it. You're able to do more and more tension with each throw. And by doing it that way, you know that you're not going to excessively cause any slippage of the knot and causing over excessive tension on the suture. So I'm able to tuck the knot into the sclerotomy. And you can see it's a well-centered lens now. And I close the sclerotomies with the 8-0 vicryl suture on either side. And then I'll close the conjunctiva as well with the same suture. The video got cut a little bit prematurely during the recording, but again, you can see how I was able to take this lens out, secure the bag and the zonules with the capsule retractors and then a capsule tension ring, as well as a sutured capsule tension segment. And despite the Trypan blocking my view, I was able to perform very careful two-handed lens disassembly techniques in order to get this lens out nice and safely, and this patient did quite well. Please watch out for the next video, which will show the fixing of the traumatic mydriasis with the pupillary cerclage using a fourth-row pupilloplasty technique. So I hope this was helpful to you, and I thank you for your attention.